Okay, it looks like we're recording. Oops. I'm going to just go back here. I'm about to turn it over to the wonderful Blueprint team led by Sarit, but I just want to call out this team, Sarit, Catherine, Caroline, Jenna, and Elizabeth. Amazing group. They have put together some really wonderful materials that are going to be helpful to all of us as we think about rolling out Lenacapavir slash Yeztugo in whatever setting we're in. They've created some really great things that will be useful for everybody. So I'm going to stop sharing my screen now and let's go ahead and turn our attention to the wonderful and lovely and talented Sarit Golub and her Blueprint team. Go ahead, take it away, Sarit.
Terrific. Thank you so much, Jim. Give me 1 second to just get myself settled too. I like to see all the people. I like to see all the chat. All right. I think I did it. It is so great to be here today. I'm going to give you guys a sense of just a little bit of our agenda and plan. I'm going to introduce and explain Blueprint for a couple minutes and our team, talk a little bit about the goals and objective for this webinar, tell you for a minute about our particular lens on lenacapavir implementation, preview our 12 lessons for lenacapavir implementation in the US as part of our Blueprint team, but then go into detail about just 5 of them. And then, as Jim said, leave a bunch of time for discussion and future directions. Blueprint is led by myself and Katrine Myers. It's a collaboration between Hunter College, the Hunter Alliance for Research and Translation, Columbia University, ADARC, and New York Presbyterian. And our interdisciplinary team represents a variety of experiences and roles. There are 5 of us leading this presentation today: myself, Katrine, Liz Ferruia, Carrie Carnevale, and Jenna Aldeeb. And I just want to take 1 minute to shout out a behind the scenes hero of the Blueprint team, and that is our program officer, Mike Stirratt. Mike has been a tremendous inspiration and has been such a critical facilitator and supporter of this work and so much other innovative and important science in the HIV prevention space and beyond. And I just, at this current moment, more than ever, we are so grateful for his leadership and insight and effort and heart. So thank you, Mike. Blueprint is a collaborative implementation science research project funded by NIH to develop what we refer to as evidence-based biobehavioral infrastructure to help clinics and service providers create, strengthen, and scale up HIV prevention programs. So in other words, what we try to do is collect and synthesize key research findings, best practices, dissemination resources that we hope can accelerate high quality, equitable dissemination of proven prevention strategies. And we have been collaborating with HIV prevention providers, capacity building, technical assistance providers across the United States, collecting data on their work and experiences. And the main output of Blueprint is our website. This is a screenshot of our homepage. And you can see that our motto is, "You don't have time to reinvent the wheel." The goal of Blueprint is to create and disseminate evidence-based but customizable tools that you can use to build or expand your HIV prevention program. At the core of Blueprint is what we call our Blueprint Program Builder, which is, it breaks the process of PrEP implementation into these 6 steps, and it's designed to provide you with step-by-step guides, SOP templates, checklists, and job aids that you can edit and adapt to meet the needs of your setting. We also have a set of curated resources on specific topics, and if you click on any of these, it's going to take you to a page where you can scroll through the list of available resources. You can see this is one related to injectables. Just a note from those of you who are already clicking on our website. When you click on a resource, you'll see a preview, and then you can download that resource to fully view it. Just depending on your browser, the formatting you see in that preview might look a little funky. Do not be alarmed. Download the resource, and it should be its beautiful self. The focus of our presentation today will be this part of our website where we talk about our 12 evidence-based lessons for Lenacapavir implementation. These are lessons from Blueprint data collection that we think can really support clinical settings that want to expand an existing HIV prevention program to include LEN, or use LEN, as we say, as a lever to start or expand their HIV prevention program more generally. And what you'll see these little cards, and if you click on it, it turns over, it explains to you what it is. Thank you, Liz. And you click on that to learn more. Each lesson is supported by specific Blueprint resources, like patient education materials or staff checklists. So what we're going to do in this webinar today is, I'll start about this in a second, is preview those 12 lessons, but go into depth about 5 of them. And then we'll end, as I said, with hopefully a lively discussion of our last lesson, which is much more policy and structure focused, and will hopefully generate ideas about how we can move forward as a research and practice community to realize the full opportunity that LEN is affording to us. But before we start, I do want to talk about at Blueprint, particular lens or perspective to this work, what we are bringing to the table today. So first, our orientation is that Lenacapavir is a lever, but not a panacea, by which we mean that we need to focus on LEN implementation, but we have to see it in the context of larger HIV prevention programs and services. And to us, the key will be expanding access. If all we do is shift current PrEP users onto Lenacapavir, we will have missed the mark. So all of our Blueprint materials integrate LEN into a larger, comprehensive prevention program and policy. Second, while a lot of our partners are clinicians and frontline providers, Katrine and I are behavioral scientists. And so we approach this work from the premise, and if you have ever heard me talk, you have likely heard me say this before, that program implementation is actually a psychological process that is treated like a logistical one, by which we mean that the success or failure of any prevention program hinges on the psychological experience of patients, clients, potential PrEP users, and on the psychological experience of providers and staff. And so the problem that we are trying to solve is how to make the experience of HIV prevention education, of PrEP prescription, of injection administration, of follow-up, of working in an HIV prevention clinic as positive and motivating and engaging as possible. So our fundamental orientation to this work is to center the user experience and perspective. And this user is both the user, PrEP user or patient or client, but also the clinician, the staff member, the advocate as a user. And our contention is that program implementation and protocol development can be undertaken in the service of these goals. And then finally, as Jim mentioned, we do have a US domestic orientation. We are focused on the, shall we say, unusual or specific way that healthcare and health insurance are organized in the United States, in which individual clinics just need to figure out processes on their own without any centralized policy or support. And medication costs are, shall we say, extremely complicated. We do, though, hope that many of the tools and resources that we've developed will be useful and applicable in international settings, but we do just want to recognize upfront both the limits of our own expertise and acknowledge that there are a lot of other amazing actors that are working to be supportive more globally. Okay, so with that in mind, here are our 12 lessons for LEN. I'm just going to read them to you, and then we'll do that deep dive. First, universalize PrEP, HIV prevention, and education. Deliver comprehensive PrEP options counseling. Center the user's experience and needs. Select and empower a program champion. Optimize workflows. Devote resources to cost and coverage. Embrace sex positivity. Lead with values and document decisions. create a culture of collaboration, leverage data, adapt as more information becomes available, and then finally go where the people are. So today we're going to do a deep dive into just these 5. Again, they're all available on the website, and then we're going to focus, we're going to focus discussion on this last one. So I'll start off with the first lesson, and then each of my colleagues will take one of the lessons and present them to you. So the first lesson is universalized prevention education, by which we mean provide basic PrEP HIV education to all clients, not just those who fit certain risk profiles or target populations. And the reason for this is that we have tremendous data that universal education reduces stigma by normalizing sexual health, and it increases access by expanding community level awareness. And this lesson emerges from our research with implementers. I do love this quote: "I provide the PrEP information to everyone. Sometimes they don't think that they're a good fit for PrEP until they go back out and say, oh, you know what? Maybe I am living a city boy life, or maybe I am getting around a little bit," and that'll make them reconsider things. As we know, and I have talked about this sort of ad nauseum before, so I'll just say it briefly now, traditional screening tools are often inadequate for identifying individuals who would most benefit from PrEP. Data indicate that universal HIV and STI screening is actually more cost effective. Normalizing this type of information decreases stigma and minimizes reactance. And universal awareness streamlines protocols and is this low-cost way of increasing community awareness. So in service of these goals, we've created a series of customizable and editable education materials. Again, they are all, you see this says here, our clinic. There's a little space for you to put your clinic logo in that particular item. They're all available in English and in Spanish. A PrEP awareness and education is our first in our program builder. And so, as I said, this is what that particular page looks like, and it has a step-by-step guide, an SOP template, and then a checklist and job aid specific to this topic. We've also created a series of patient education materials focused on injectable PrEP. And all the materials, unless they specifically are noted, include information both about cabotegravir and lenacapavir as injectable PrEP. So I did say that we're only going to do 5 topics, but I can't help myself because one of the other ones is so close to my heart, and that is embrace sex positivity. I'm sure you're all familiar with the PrEP for Love campaign. I don't know if you've seen this new one. We can't show you all the benefits of PrEP. It's a new campaign out of Denmark. Many of you are also likely familiar with the Pleasure Project. And I just want to shout out the fact that we have more and more data that sex positive messaging motivates sexual health and prevention behavior and facilitates open discussion and engagement with clients. On the BLUPrInt website, you'll find information about something called the GOALS approach, which is an evidence-based framework designed to address and overcome many traditional challenges with sexual history encounters. So it normalizes sexuality as a core component of health. It centers patients' needs and sexual health concerns. It reduces bias, and it streamlines conversations to focus really on agency and empowerment. And I want to shout out our recent research collaboration with the New York City Health Department, in which we demonstrated that using goals was actually associated with increases in offers of all these different HIV prevention interventions. And this was just published in a special issue of Psychological Services. So with that, I'm going to turn it over to Carrie for our second lesson.
Thanks so much, Sarit, and thank you all for being here today to discuss this really important but also equally exciting topic. So in this section, we're going to kind of touch on our portion of the website entitled Delivering Comprehensive PrEP Options Counseling. So some of you may be aware of this term, options counseling, from strategies around comprehensive birth control education. So now that there's more than just a daily oral option for PrEP, we have the opportunity to use options counseling with patients to clearly outline the pros and cons of each PrEP modality. Using options counseling and shared decision-making with PrEP choice has been shown to not only increase PrEP uptake, but also persistence and use over time. So in order to provide clear and discernible choices to patients, a discussion of how each option interplays with the physical, psychological, social, and financial well-being is necessary. What's also super important here is this is more than just a list of PrEP options. It's also what factors are most important to the patient so that a PrEP choice can be made, that it has the best chance of meeting the patient's needs and expectations. Next slide. So before I dive into PrEP options counseling with a patient, I start with an open-ended conversation about their sexual health goals. And this way we can start from a place of sex positivity, where the patient can express what's happening in their current sex life, and then we can see where PrEP can fit in. And then this will help them achieve their ideal sex life and also maybe ideal quality of life. Potential and current PrEP users have the right to fully understand the pros and cons of each HIV prevention option, including, but probably not limited to, side effects, potential drug interactions, costs, both financial and the time spent, logistics, so frequency of testing or frequency of appointments, and implications and flexibility to stop and switch methods should they see fit. And this is a great quote from BLUPrInt's participant qualitative interviews that I also really love. I talk to them about their sex life. I need to know you as a person. It makes it easier for you to be honest. It helps me to be able to navigate your care better and meet your needs better. So I want to know what your dreams are. I see them as a person and treat them as such. They matter. I don't just talk about PrEP. I talk about their lives and what's happening with them, and then PrEP comes along. Next slide. So when discussing LEN as one of the options in PrEP counseling, here's a list of some educational points that we want to touch on to ensure this is a right fit for a patient. So I'm sure as LEN rolls out, there's going to be more to this list. Right now, here are the ones that we consider to be kind of important and also great opportunities for us to expand on research involving LEN implementation. So I think discussing about the nodules with patients first is probably the best educational point. It's very important for patients to know that there's a formation of a palpable, but usually not visible nodule under the skin after the 2 LEN injections. This is common and should be expected. So while the nodules are common and should be expected, in studies, about 35% of patients didn't feel the nodules with the first injection. And people actually felt fewer nodules with subsequent injections. So I think this is super important to mention to patients so they don't get worried if a nodule does not form and have concerns that the medication somehow did not get absorbed correctly. So then the next topic I think is really important as a first initial, like this is LEN, is the leakage. So since Lenacapavir is a viscous, long-acting medication, some leakage may occur, but this is just a small drop and it's normal. It's common to see the drop of medication or blood at the site of injection after the needle's removed. This does not mean the dose was lost. This is not a cause for concern, but super important to tell patients so they're not thrown when they get their injection. On our website, we're going to have recommendations for ways that you can kind of reduce the amount of leakage. So some of those are inject the medication slowly or wait before removing the needle, but check out our website and we'll have all those topics for you. The next topic that I think is important is timing and paperwork. So if I'm seeing you today and you want to start on PrEP, and you're interested in long-acting medication, but more importantly, you want to start on PrEP and you're here in front of me right now. I want to make sure to paint a really realistic picture of the timeline for that patient as we start to get the long-acting injectables approved. So the turnaround for prior authorization and acquisition to our clinic for CAB-LA right now is about 3 to 5 days. LEN, we're hoping for the same or shorter, but right now we don't have a great picture from all the payers. It may be in the patient's best interest to consider starting on an oral regimen today while they're in front of you, while we await for the approval and arrival of the injectable medication. So not only does this give the patient time in between while we're waiting to make sure that they continue to stay HIV free. But also as a clinician, it's great to know that the patient's also being protected during that time, so you can feel more confident about Len being administered when you finally get it. All right, so conversations about drug interactions. So we're just learning a little bit about this as far as like real world implementation. I think this is going to be super important to dive into more as we start rolling this out, but just to touch on these 2 specific drug interactions that we know about. So the erectile dysfunction drugs. So these are Viagra, Cialis, Levitra. All of these, lenacapavir significantly interacts with these medications due to inhibition of the CYP3A4 by Len. So what does this mean? If I'm on lenacapavir and I take an erectile dysfunction drug, I'm going to experience prolonged and painful erections lasting more than 4 hours, possibly cardiovascular issues like chest pain, irregular heartbeat, or hypotension, sensory changes, including visual disturbances and hearing loss. So while this sounds scary, I think we don't know what this looks like right now. And there's been talk about titration of the ED drugs down, so giving smaller doses. We don't have data on that. That would be great to find. But also, I think another thing that I've been thinking about is a lot of my patients get their ED drugs externally. So while I do prescribe some, a lot of them get it from either their friends or an online telehealth company. So I might not know just looking at their chart that they're on these medications. And also I might not know in the future that they want to take these medications. So I think making sure that we're talking to every patient about this interaction in the case that they might take these medications is very important. Also, these drugs all have different half-lives. So like Cialis's half-life is 18 hours and Viagra is 4 hours. So, that could have a different interaction with people. Does Cialis have less of an effect? Is that something they should be using on Len? All good questions for brilliant researchers. But those are things that we need to kind of at least lay the groundwork for with patients. Ketamine. So ketamine concentrations may also increase due to the same inhibition of CYP3A4 by Len. It may increase side effects associated with ketamine, including profound sedation, central nervous system depression, respiratory depression, dangerously low or ineffective breathing, cardiovascular issues such as elevated blood pressure, intense psychoactive effects, including hallucinations and psychosis, and potential overdose or death. Dun, dun, dun. So it's really important to ask patients, not only do they have a history of ketamine use, both via prescription or via recreational use, but also some patients may not know if the recreational drugs they are taking have ketamine in them. So I think just probably regardless of PrEP options counseling, I think a frank conversation about drug use and also thoughts and education on future drug use with the patient is necessary before starting on Len. Ketamine's a lot more common right now for treatment of chronic depression. A lot of patients are finding a lot of relief with ketamine. I think we just need to be very aware of this interaction and make sure to educate patients as such. So the tail and stopping and switching. So we're a little bit more versed in this because of CAB-LA, but patients should be counseled before starting Len that the medication can stay in their body for up to 12 months or longer after they stop injections. Patients also need to be aware that 6 months after their injection, if they remain concerned about HIV exposures, they will need another form of PrEP to keep them entirely protected against HIV. It's just important for us to keep in mind, this is not the most flexible of administrations if a patient would like to switch. But still an option after 6 months, but keeping in mind some kind of form of HIV prevention during that time is helpful. So anticipated and unanticipated bridging. We gave Len this week for PrEP, and I said to the patient, okay, see you in March. And I felt like that was such a crazy thing to say to a patient. And I think making sure, what I'm doing in 2 months for a CAB injection, like I can schedule that out probably. Do I know what I'm doing in March? Like, maybe not. I don't know. Maybe I'll be in like my Caribbean island away from it all. Who knows? But I think making sure that patients can figure out how to navigate bridging or anticipated or unanticipated bridging. So I know the pharmaceutical company has lenacapavir tablets. that are available, but we're not sure how available they're going to be in pharmacies yet. So does bridging look like giving TDF-FTC or TAF-FTC instead? These are all options for patients, but the discussion needs to be had of what 6 months from now look like for you. Okay, so those are some, just a little taste. Here is a shot of our website. So these are examples of some of our Blueprint materials. Prep options counseling comparison chart. We have one for users and providers, and the prep user one is available in both English and Spanish. Videos about the long-acting tail to support user education is available in English and Spanish. These are awesome. They are great to use with patients. And the counseling aid considerations for injectables that has a series of topics to engage patients, summary language, and then questions to guide potential users. And then additionally, we also have this section on our website that reviews some program staff and development resources that we created with customizable templates to use at your sites with your teams. And now I'm going to hand it over to Katrine.
All right, thank you, Carrie.
Yeah.
So our third lesson is about centering the PrEP user's experience as we think about how to organize and deliver PrEP services generally, and also injectable PrEP services. What this means is that we need to think about how the interactions that clients have with our healthcare system in general and with our clinic specifically impacts them both emotionally and also cognitively. And once we recognize this, to me, it feels very powerful because it feels like it's allows us to make changes in how we organize and deliver PrEP care in ways that signal to our clients that we recognize their reality, we empathize with them about that reality, and we prioritize their well-being. Because we are researchers and believe in grounding our work in evidence, which I think is more important today than ever before, Blueprint resources include links to specific scientific papers about the user experience, including our own research on clinic-level strategies for decreasing stigma, resources for understanding and defining patient experiences in healthcare, social psychology research on the role of patient-provider interactions on healthcare engagement, and a piece that describes using program implementation very intentionally as a strategy to disrupt stigma. So all of this work is fundamentally about how cues and expectancies shape users' experience, especially in the context of an injection that's delivered in a medical setting. What we say, what our clinics look like, how we engage with clients, eye contact, body language, all shape the experiences that clients have and their emotional and cognitive responses to those. Clients are evaluating providers by how they are being treated. They are asking themselves, am I being judged by this provider for how I live my life? Does the clinic care if I make my appointment or not? So as a result, one of our goals in Blueprint is to help agencies consider the patient experience when they are developing their PrEP programs and protocols. Each of our PrEP program components is designed with prompts to help you consider the way in which potential users are experiencing each step of the process, even things like how medication is procured and arrives in a clinic, and the cost of the medication to them. So with that in mind, I want to share some strategies that we've identified through our work with our partner clinics across the US. These are not rocket science. They are things that are within your power as agency leaders, managers, or staff to either advocate for or simply do. So for example, extending clinic hours. Now, I know that that's not a simple thing. It means making sure staff are available, including everyone from clinical staff to support staff to building security. But we have heard examples of clinics extending hours specifically for their clients on injectables as a first step, and then being able to grow those extra extended hours to encompass the rest of their patients. It is possible. We've seen it happen. Walk-in appointments. This may be a little bit counterintuitive to put on a slide about centering experience, the user experience for injectables, because walk-ins for injectables may be not be possible right now. But we found that opening walk-in appointments for clients who are not on injectables may then open up scheduled appointments for the folks who are on injectables. Integrating wraparound services into visits with all clients has 3 advantages. First, it ensures that we don't make assumptions about who does or doesn't need wraparound services. Second, it communicates that we care about what else is going on in our clients' lives, that we may have the opportunity to help or figure out how to refer for. And third, building on something Sarit said earlier, it actually simplifies workflows for staff if they know that they're doing the same thing for all clients as a baseline. And it also allows the client's self-identified needs to drive the next steps. So this example also speaks of the ways in which having a protocol that standardizes those things, standardizes what is offered to clients for wraparound services, also operates as a strategy that centers the user. We've heard from some clients, particularly those that feel like they've been labeled as unreliable or not adherent or compliant. The clinics are encouraging the use of injectables on them in a way that it feels paternalistic and deprives them of agency. For example, a campaign that a clinic started that says, inject it and forget it, was very well intentioned, but what it communicated to clients is that they could be injected and then forgotten. For this reason, this clinic then sort of, got feedback from the community and started doing check-in calls or text messages the day after and the day after, the second day after the injection, just to check in on how the client is doing with no other motive. And strategies like that can be extra powerful. The physical environment, what the clinic looks, smells, feels like, also matters, and I'll go into that a little bit in the next slide. And finally, when developing clinic workflows, think about how they communicate the respect that you have for your patients, the dignity that they are due, and also their confidentiality. So here, getting to concrete ideas for injectables for strategies around injectables that center the user. Here are some examples that we've started hearing about. Signaling recognition and empathy by providing an ice pack that is used before the injection to apply to the injection spot, before as well as after, can just show that you're thinking about what the experience of getting an injection is all about. You can demonstrate inclusivity with the availability of patient-facing materials in different languages. It shows that we understand that English is not everyone's native language, and that making the extra effort to have materials available in languages that can be more easily understood is super important. Recognizing that it is easy to forget instructions and taking the time to set an alarm on the client's phone to remind them to take 2 pills the day after the injection is another strategy that can be employed. And then finally, showing that we prioritize clients' experience through the physical setup of the injection room can be super powerful. Here's a picture of Whitman Walker's injection room. You can notice the plant in the corner, the wall hanging of a relaxing beach scene, the exam table that's actually a massage table, and then even an aromatherapy diffuser in the corner. So we integrate this tenet of centering the user experience throughout all of our materials, but the component called motivating, engaging, and retaining patients is a place to go to look for resources for program and for staff development that provides more concrete guidance in this area. And then you'll see our step-by-step guide, sampled SOPs that you can download and again edit to work for your clinic, as well as job aids in the form of checklists. As Liz mentioned in the chat, everything we make is totally modifiable. This is intentional. We want you to download these and make them your own. With that, I will turn to Liz to talk about our next lesson, optimizing workflow.
Hi, everyone. So thank you so much for joining. In delivering prep services, a lot of people have a lot to do across many institutions, and it's all time sensitive. And so we just wanted to take a few moments to highlight some strategies that have been particularly effective in optimizing the workflow. So that's embracing task shifting, cross-training staff, redesigning workflows, partnering with external vendors, and using electronic tracking tools. And on the next few slides, we'll talk about some of the tools we've developed to support the execution of these strategies. You've seen these mentioned throughout, but just to hear it all in one place, the Blueprint Prep Program Builder breaks down the process of making PrEP, whether oral or injectable, available in your clinic setting into 6 manageable and coherent program components. These are PrEP awareness and education, PrEP options counseling, navigating cost and coverage, procurement and storage, prescribing and administering, and motivating, engaging, and retaining patients. And so each component walks through the key decisions that are necessary to start, refine, or scale up a PrEP program. And taken together, they form the basis for our PrEP protocols. Formalized protocols have a few key benefits. You might be wondering, what is a protocol and why go through the time-consuming effort of building one? Especially when there is just such a powerful urge to get started. So protocols, firstly, provide logistical support and reference. At a most basic level, protocols provide staff with guidelines for how to proceed in certain situations and sets out the parameters within which to operate. It saves time when people don't need to regenerate what to do each time and can just refer to a standardized document. They also promote institutional memory and continuity. So sometimes staff leave abruptly, and we need to pass that baton quickly and efficiently to new staff. It also helps to ensure an intentional and consistent client experience and to protect institutions and organizations against unconscious bias. So for example, if one provider in the clinic is very generous with their PrEP refills and another is more stringent, if I, Liz, am getting a refill every 3 months, but my good friend Sarit is getting at that same clinic refills every 6 months, I may feel some type of way about it and wonder if I am being judged as a less reliable patient. So protocols can be very powerful in ensuring that consistent client experience. Protocols also create formal mechanisms to reflect on an organization's values and the way that the values are enacted in practice. And lastly, they establish a framework to evaluate progress. So you can associate changes in your PrEP outcomes, potentially how many educated or started on PrEP, with any changes in your protocols that you adopt. So the workflow and staffing table documents that we've created are intended to be a simplified representation of your protocols or a quick reference. Aligning on the organization and articulation of labor can be a powerful tool to help overcome some of those implementation barriers. Making sure that everyone is on the same page about who is doing what, when, and where it's being documented mitigates the risks that things will fall through the cracks. It may also be helpful to see how responsibilities are distributed across staff. So if the bulk of injectable PrEP responsibilities fall on a particular role, it may make the case for redistributing that workload or hiring more people. It can also be helpful in investigating where bottlenecks are occurring. Another powerful strategy to optimize the workflow is task shifting, redistributing responsibilities from highly trained staff to other professionals with less specialized training to improve efficiency and access to care. And this has some overlap with cross-training of staff, which is allowing staff the flexibility to perform multiple roles to increase efficiency and teamwork. And from the patient perspective, what this might actually allow is for them to have just 1 or 2 points of contact as opposed to many different people within an organization. We'd just like to take a moment to highlight the June 26th AVAC webinar moderated by Rupa Patel embracing task shifting and innovation to support expanded access to long-acting injectable PrEP. And 2 blueprint resources that we'd like to highlight is our glossary, which is a great resource for task shifting. It helps orient staff who are new to the PrEP space, as is our detailed checklist for injection visits. And lastly, something that we are very proud to present are our digital tools. So we have an interactive status neutral safe injection calculator. This calculates the window of the earliest possible safe injection date and the last possible safe injection date based on the person's most recent injection of their cabotegravir or lenacapavir. So this can be a quick, handy reference when scheduling, or equally as important, rescheduling visits. Does not collect or store any patient data. It's just an automated calculation based off of that injection date. We also have an Excel mini module, an Excel reminder tracker, which helps to keep track of which patients have actually received reminders for their upcoming appointments. And a procurement tracker to keep track of where things are at with insurance, which prior authorizations have been completed, the status, and the medications once they physically arrive. So we chose to program this in Excel, giving people access to a free, secure, and locally stored way to manage this data. And coming soon is our access tracker. You will find this is going to be available on our digital tools page at the top, as well as at the top of our navigation bar. So as this access tool is made available, this is where to go. And with that, I am going to turn it over to my colleague, Jenna.
Before Jenna goes, I just, I love that somebody was like drawing on their screen about our resources, but it's shown up for everybody. So, and I don't know how to erase it. I swear it wasn't me. So what I'm going to do is I think I'm going to stop sharing for a second and see if it goes away when I re-share. And I think it did.
Yay!
Give me a second. I'm gonna go down to Jenna's portion. Sorry, Jenna.
Thank you for doing that.
Problem. Thank you.
I was
Right, I
wondering
think we're good.
what that doodle was.
I don't know. It was
changed the
it just
doodle.
it had a little person's name on it when they started writing, and I'm excited that you wanted to do that, but don't do it again.
All right, let's get started. Thank you everyone for joining today. Now we're going to be jumping into our next lesson for Len, Devout Resources for Cost and Coverage, focusing on procedures to overcome barriers to access. So in the long-acting injectable realm, there are many components and even layers to starting Len. And as we touched on today, excuse me, we have the initial clinical decision-making, the interactive user experience, and some workflow strategies. But there's also the practical piece of acquisition, where insurance coverage comes in and plays a major role with nuances like prior authorizations, different benefits breakdowns, and also there's a component of operations within the clinic to document, track, and bill accordingly. So putting all the resources together, we have summed them up in some tips. So firstly, in my experience, there are two main helpful resources for navigating cost and coverage. First, we have partnering with a pharmacist in an HIV specialty to help troubleshoot issues directly to help expedite the process. And then second, we have utilizing the manufacturer resources available through Gilead's website, which we'll also look at later on. At New York Presbyterian, for example, we have our enterprise pharmacy and a team of liaisons that help in this partnership piece. But we also utilize alternative relationships with other specialties to increase patient access. And sometimes we have to abide by insurance preferred pharmacy requirements. So we utilize other pharmacies like AHF, Accredo, CVS Specialty, those being directed by insurance coverages. As for Gilead, they had put out some easy to follow resources and guides with information for both healthcare professionals and patients, with information such as specific diagnosis and billing codes, copay assistance, patient assistance, to ultimately help in the process related to acquiring and retaining access. And these are some snapshots of the resources here for Len4Prep. These are on the healthcare provider page. There is also a patient access page that has some different information. And on this page, it includes some step-by-step guidance, assistance with medication access, billing, and some other related information. And then some of our other tips include those related to our electronic medical records, our IT issues. So given that Len is being used for both treatment and PrEP, uniquely under two different brand names, our EMRs will need specific build outs to, appropriate to ensure that billing is being captured for the correct indication of the drug to indication combination. So for example, when this first came out, we were discussing it in my institution, and there was two different ways we were discussing on doing this. So first we would have like Lenacapavir with both of the brand names together, and then it would branch off when the providers were ordering, it would branch off for PrEP and then for treatment, and then it would go to the medication either for loading dose or maintenance, and that way it would trigger a certain billing. But with this option, and then it would link to that specific code, so all the billing would be appropriate. But we did discuss some potential errors that this might cause. Some of those are misdiagnoses in the patient's chart. So if somebody else was doing a patient chart review that was, in an inpatient facility, or if they transferred to another facility that didn't know the patient or didn't know the history, it might lead to some misdiagnosis. Some of the others were misordering to the pharmacy. So if they chose the wrong indication by mistake, because the generic name would show up first. So if they sent the wrong brand name to the pharmacy, then it can create some delays, where the pharmacy would then have to call and like verify, especially if it was a maintenance or a continuation dose. They would have to call and verify if the patient's switching or if they're staying on the same one, and then they would have to resend the prescription. So it does create a lot of back and forth. And then the other was also potential creation for billing errors. So that would also, choosing which option would link to what type of visit it was going to be. And some insurances have some nuances with prevention visits versus treatment visits, and those might cause or create different costs for the patients. So this led to our second option, which was basically just separating them out into two separate individual orders. That way everything is on its own platform, and there was no issues in that regard. And it's also easy trackable in the patient's chart for if they went somewhere else down the line. For our next tip, it's following up with pharmacy regarding insurance rejections. So if Lenacapavir claim is denied when the pharmacy is processing it, normally the rejection will have a response on it. So either it needs a prior authorization, it's not covered, it's not formulary, but it sometimes has some next steps alongside it. And one of the ones that I had come across, it being for Len4Prep specifically, was it being non-formulary. And then after that, it said patient must have tried and failed alternatives such as Rukobia and Trogarzo. So with this rejection, it entails that the insurance is recognizing that medication is being used for multi-drug resistance HIV treatment, not what we sent it for, which is for prevention. But this rejection also doesn't tell us anything about PrEP and its coverage, right? It's just telling us the patient should have tried and failed this option. So this could mean that the indication has not been added or reviewed yet for the formulary. So we have to do some more investigation with the insurance to see if there is coverage for it. So then how did we resolve this? We submitted a non-formulary PA, or we denied and we appealed. Sorry, we appealed the deny with the correct indication that we intended to use it for, which in this case was prevention. And this happened in two different instances with two different insurance companies, and both of the insurance companies did end up approving it once we had sorted all that out. And then if at first we don't succeed, it is noteworthy that some plans evaluate new formulary additions within 90 days of FDA approval. However, some insurance plans reevaluate every 6 to 12 months. So when this medication can initially it becomes non-formulary or not covered or even covered, coverage restrictions, sometimes it's medical benefits versus pharmacy benefits. So it can somewhat or potentially change on the next review period. So in the HIV space for any of the injectables, personally, when I'm doing these checks, if something was denied in the beginning of the year or at some point, I would retest, usually in the end of January and the end of June, just to kind of cover that every 6 months, 12 months basis. And for other drugs previously, that has worked, where if we wanted to move someone from medical benefits into pharmacy benefits, at the next, after 6 months later, it did move over coverage. So we're able to utilize that as well. And then for Medicaid, coverage options and restrictions will vary state by state. So for each individual state, we'd have to refer to the state prescription drug list. And so for BLUPrInt, as we mentioned, we had developed many resources. And on this one, I would like to point out the frequently asked questions sheet shown here. And we also have the modifiable version of the checklist to assist with navigating this process. And it could also be used for training staff and just reviewing. And it is modifiable. So it could be tailored specifically to each site using it. And with that, I would turn it back to Sarit.
Awesome. Okay, so we have shown you a lot in the last 55 minutes, and we hope that you will spend time after this session reviewing and delving into the resources that are most useful to you. And maybe folks have been a little bit quiet in the chat because you're looking at all this stuff. I do want to make a huge caveat, though, that we are researchers, providers, and trainers. We are not ad executives or graphic designers, and we do not have a budget of a pharmaceutical company. And at the same time, we felt strongly that it was important for you to have access to materials and resources that are not generated by or branded by pharma. However, as we said, all of the resources are available in editable format, Word, PowerPoint, so you can feel free to adapt them, not just to your needs, but also maybe to your clinic's own brand or your own design sense. Like, our goal is just to save you time, to start you off with materials that have already been generated so that you can then spend the time making them your own. And now for a shameless plug. This is my favorite picture of a shameless plug. Please, please, please join our BLUPrInt community. This is a very brief evaluation survey about the webinar. And at the end of it, it lets you opt into our mailing list to learn more about all of the different offerings that we are planning in the coming months. So Jim just put that in the chat. Please take a look at that. Okay, our last lesson, and this is what I really hope we'll spend some time discussing. Go where the people are. Increasing PrEP access means going outside of our traditional delivery settings and forging new cross-disciplinary partnerships, because we know that we have not done enough so far to reach HIV prevention to communities and individuals that need it most. And so we really need to build capacity and involve a variety of providers across settings, really thinking outside the box, emergency departments, family planning, safe injection sites, transitional housing. And so this is what I really hope we'll spend some time discussing. And I'll go through these questions quickly. Jim will post them in the chat, and then I'll stop sharing so that we can see each other and really have a conversation. So my first question to folks is, how are we really going to reach new populations? What are we going to do to make sure that the promise of Lenacapavir is a lever and not a letdown to communities that we have committed to serving? What additional resources are necessary to support PrEP providers in forging new partnerships or developing new delivery models? How can we make sure that users are presented actually with options rather than just being sold this new thing? How can we get better information about users' experiences, as Carrie mentioned, that will truly help informed consent? And then finally, and this is something I have spoken about before, what power do we have as providers, as advocates, as researchers to hold the pharmaceutical companies, Gilead and ViiV and Merck, and I know some of these folks are on this call, accountable for their profit margins, for the amount of profit that they are making. Not to say that they shouldn't be able to make profit, but the amount of profit that they are making on these drugs. So those are our questions. I'm going to stop share. I'm going to turn it over to Jim to moderate our discussion. Thanks so much for having us.
First of all, Sarit and BLUPrInt team, you all are amazing. The chat loves you. You have made so many really great resources, so thoughtfully put together. So can we get some emojis, some love and the emojis on the chat for this team? And then we're going to get to the juicy discussion. So there's a number of questions that have been laid out here. I recognize a lot of the people on this webinar, and there's not a lot of shy people here. So would love to see some hands raised for people who want to address one of these questions that Sarit and team have laid out, or pose another question. Is there something that you would like more information on, something that you would like to talk more about? This is your webinar, so please, I'll give you a second to think about that. There is a question that has just come in the chat from BR. What are you hearing about how widely or narrowly Len is being covered by insurers? Gilead has been bullish on this, but are they right? Would someone like to take on that question from the team?
I would punt that to either Carrie or Jenna. Yeah, go Jenna.
I was just going to say it is still new on the market. So there are insurance companies that are still evaluating for their formularies. I believe the last information we had, it wasn't covered by Medicaid yet. But for some of our other insurance plans, we have been able to get it coverage. So we've had success, I think, with at least 3 patients. So it's getting there. It's just because it's still early on. It's a little bit hard to tell. We need at least, I think, a little like 2 more months or so to be able to determine kind of how accessible it is. But so far, it has been a pretty smooth process.
And I will note that CVS came out last week and said that its PBM and insurance company would not be covering Yeztugo. So this is definitely a space to be watching. I have personally heard that Medicaid has been covering it, but other private insurers has been hit and miss, and there's been a fair amount of rejections. But I think to the points made earlier, insurance companies count on people giving up and count on people getting tired and not appealing and fighting the rejections. So unfortunately, that does take a lot of time and energy from both the client and the clinic space, but fighting back on rejection often has results in success.
And I was just going to add to Jenna's comment that private insurances this seems to be easier approval right now. We're still waiting for Medicaid as of this morning, so we'll see.
So are there other questions or comments from the group, or we will start going through and maybe have the panel start weighing in on some of these questions? I'm going to take the moderator's prerogative and go out of order a little bit here. And something that I've been really concerned about since we've had, we're seeing a pullback from public health and the government in spending money on our efforts. And the folks left with money at the table are pharmaceutical companies who have vested interests in their own products and without public health goals in mind necessarily. So I would love to hear what people think is how we help make sure that users are presented with true options and they're not being sold a new thing, that the person sharing that information is not putting their thumb on the scale for whatever thing gets them excited or whatever thing their pharma rep has gotten them excited about. How can we do that? How can we make sure that we're laying out these options without bias and without thinking about, quite frankly, our own 340B revenue? So who would like to jump in to anything I've said there?
I also saw someone come off camera and take their mic off for a hot minute, and I was wondering, Renee, I wonder if you wanted, did you have something to say?
Yeah, I wanted to say something about
Please.
coverage. So just because I'm from Howard Brown, a PrEP navigator. So we do know that Blue Cross Medicaid covers UpRight, just because recently worked with a patient. With some other patients or in other insurance plans can be a little bit more tricky. Like I submitted a prior authorization recently, and then it got denied because they wanted like evidence that the patient had tried and failed like UpRight. And then for other patients, they require like a specialty pharmacy acquisition, which is also like a little bit more like time consuming and more complicated. And then I think there was like one patient that actually had pharmacy benefits. So we were able to get it like at a local Walgreens, which was really nice. So I think it all depends, and then on the specific insurance plan. And I think that eventually they might start putting them on their formulary, but it may take a while.
Anyone want to comment on those, on his comments?
No, but I see a couple things in the chat that I might say something
Please.
about. Tommy talked about integrating LGBTQ plus curriculum into the program, which I think is amazing. This is not something that we have on the BLUPrInt website, but it is something that we aspire to provide links and resources to as well. I see Nanette's question about how applicable the tools are to other long-acting injectable options for both prevention and care. And I just want to underscore two things. First, that all of our tools, almost all of our tools that talk about long-acting injectable PrEP talk both about cabotegravir and lenacapavir. Our focus today was lenacapavir because it is the new thing and what folks are sort of interested in talking about. The other thing that I will say is, you know, a status neutral approach is also so much a part of what we understand is sex positive and stigma reducing and affirming in general. And so while BLUPrInt is specifically funded to focus on prevention, our digital tools, for example, are status neutral. And so they all have they allow you to keep information on your patients, whether they are engaged, whether they're using injectables or other PrEP products for prevention or treatment. And our hope is that integrated programs are really the future of HIV.
Thanks, Sarit. I don't see a lot of people biting on how we share options in a way that is unbiased, but I think it's something we all really need to be careful about. And using resources like BLUPrInt can really help. When we use resources from pharmaceutical companies, they're all coming with an agenda. We have to just say that it's just the way it is. Pharmaceutical companies are here to make money. Public health is here to help people stay healthy, and these things don't always combine nicely. The more we can be really fair with our clients and support them in choosing exactly what will be the best fit for them, it's their choice, and it'll help ensure success. But another question regarding users or people who use PrEP, and Sarit mentioned this at the beginning, we will have failed if all we do is switch people from one modality to another, from one PrEP modality to another. Certainly people have a right and should switch for things that they think will be better for them. But how do we find new populations? How do we get folks who have not been able to access PrEP for whatever reason and may be interested? How do we bring them in? I think that would be a great question to discuss. And Nanette, did you want to speak to that question? And you are on mute, my friend.
Thanks, Tim. I wanted to speak to the first part when you started speaking, and that is
Okay.
in terms of choice for clients. I don't know if this already exists, but it seems that it would be helpful to have a bit of a decision tree or a true options for clients. So, the pill versus LAI versus type of LAI, like what is best for you? And what are examples of what might be best for you? A tool for clinicians or staff to be able to walk the client through what might be best. And I've been thinking a lot about this for 211. So your behavior, your risk taking, your, whatever fits in your life, which of those are best for you? And I don't know if something like that exists or if it's, one of the great tools that you have in your toolkit.
We in the options grid, there are a lot of different sort of pieces and considerations. And in the options counseling checklist, there are a bunch of prompts that are designed to help counselors engage with clients on some of those questions, and the ways in which the different options can be the most supportive of the type of sex life, and as Carrie said, sort of a sex life and also ideal rest of life that the person wants to have. But I think that is an incredibly important piece to constantly keep in mind.
Thanks.
Thanks, Annette and Sarit. I will pivot to a question in the chat because this is something we're seeing come up a lot in all kinds of media coverage, and it seeps into the community. And this is from Omar. How can we help communities better understand the difference between long-acting HIV injectables and vaccines, especially given that some people may confuse the two, and some people do confuse the two, and the current political debates around vaccines could create misunderstandings and cause issues with access. So would the team like to speak to that?
Carrie, I thought I saw you moving toward, yeah, go ahead.
Yeah. So it's a huge, I mean, it's a PR problem. And while we would all love to have a vaccine, we don't have it. So I think being like whenever you can with patients, making sure to say like, well, no, we don't have a vaccine yet, but this is treatment, medication, treatment. I also think that another thing that makes me nervous about this is, the tail and folks thinking that this is a one-shot deal and all of the miseducation that goes along with that. I think before we even, I know with Apretude and with Caballet and even with Len now, moving just to inject without having a really comprehensive educational package is dangerous. And I think having a conversation about this is not a vaccine, this is a medication, and it will stay in your body if you don't get another injection past the 6 months, that could lead you to be more susceptible to resistant HIV. I definitely think that needs to be said to everyone, because I've definitely adopted Caballet patients from other places where they've thought that this was like a vaccine and that if they can stop and they'll still be protected. So I think readdressing the misinformation is really important.
Yeah, and I think what we tried to do in our counseling materials, and like I feel like every time I hear amazing comments, it like makes me want to do even more. But what we tried to do in the options counseling, and I like the comment in the chat that we do sort of try to take a family planning or a contraceptives type lens on this about like what the pros and cons of different options might be for a particular user. So our general options counseling like lays out some of the high level big picture considerations that somebody might have. And then especially our injectable materials, because injectable is so much more complicated, goes through in much more detail the types of things that we're gonna have to talk to patients about. And I would say to specifically check out our considerations for Len, which includes both, oh, look at you, you're amazing. Liz is like anticipating my every thought. Because it includes sort of like these types of considerations in plain language, and then it also gives you some bullets of discussion points that you might want to have with a patient. And like one of the things that I think is just true again within the US healthcare system is that folks have exactly 75 seconds to talk with their patients about things that really require much more time, and that is going to be something that I think that we're struggling about.
I also just wanted to add to Tammy's question. So I love it. I think I don't want to lose the on-demand as an option for patients in all of this. I think a lot of people are like, I don't like pills, I want injectable. I think on-demand we know works. We definitively know it works in certain populations. We kind of know it works in some populations. I think moving straight to injectable because somebody doesn't like pills or doesn't like taking a pill every day, I think explore on-demand as well.
Thanks for bringing that up, Caroline, because we are learning more and more that 7 pills a week, a pill every day is not necessary for high success. And we've known that for some time with cis gender men, and we've gotten a lot more data around cis women also having full protection commensurate with 4 pills a week. So I think the construct of you being able to take a pill every day, we definitely need to dive deeper. I mean, that's something to think about, but we don't actually need perfection in pill taking from anyone to have high levels of success. And I think that's a message we also have to work to undo, because unfortunately for cisgender women, the message for them for the entirety of PrEP, really into the last year or two, has been you need to be perfect at adherence. You need to take it for a month before you're protected, and then you need to take it every day. And both those things are not true anymore. We've learned from science, so I really appreciate you bringing that up.
I just want to really lift up what Maribel and also Chibuzo have put in the chat about reaching populations that either are traditionally left behind or are out of sight, or that we know are important, but all of a sudden are no longer being prioritized in the way that they should. And I think that it is imperative for all of us to continue to advocate and sound the alarm about exactly, I mean, go where the people are, that we need to follow the incidence data. We need to follow the information that we know about populations that have not gotten access in the past. I don't, Chibuzo, I'm not gonna put you on the spot, but yes, we need to go into carceral settings, and long-acting injectable would be, I think, in some ways, an amazing option for folks in that setting, and in a whole bunch of other settings that we have really done a bad job of envisioning strategies for. So I don't know if anyone also wants to just weigh in on how we can work more creatively to go where folks who need these services actually are.
Anyone want to jump in there?
I will. Hi, Jeff. This is
Chibuzo.
Cameo.
Yes.
Hi, Chibuzo.
Oops.
Okay, we have everyone jumping in. So Chibuzo, you want to follow up, and then we'll go to Cameo.
Sure. Thank you so much. And thank you, sorry, Katrine and team and everyone involved for an excellent webinar. Yeah, so folks who don't know my name is Chibuzo Yeztugo. I'm with New York City Health and Hospitals Correctional Health Services. We're in the New York City jails on Rikers Island. So yeah, so the comment I made really was in response to another comment about specifically cis hetero Black men, kind of not always in the conversation. And, our population here, jail population, is, close to 90% Black and brown folks, almost 95% men. So we do see that population here, and folks, don't have a lot of awareness or knowledge about PrEP. And at the same time, we have folks that come in who do have education and knowledge and are asking for long-acting injectables, whether it's for prevention or treatment. And so a lot of the challenges that we run into here is not even like lack of access for long-acting injectables. Folks who come in on Cabenuva, we can continue them on Cabenuva. The issue is once folks leave here, the re-entry piece, I think, is the part of all of this that we really need to get very creative about. We partner very well with other health and hospital sites, with the Department of Health, Mount Sinai, other organizations around the city, but there's still that piece of when people leave here, getting them, linked to services and to care is very challenging. And I will say what's very exciting about long-acting injectables in general is that when folks do leave, we do have, a longer window to get them secured into care. The challenge with that, it's also a longer window to kind of lose folks. So yeah, again, great talk, and yeah, just thinking about how to get folks linked into care once they leave here.
Thank you so much.
Thank you, Chibuzo. Cameo, did you want to jump in?
Yes. So hi, my name is Cameo Montemedici. I work with UI Health Emergency Department, and I don't really have necessarily any good answers. I just want to put this out into the universe to see if other people can help me manifest my dreams of trying to get long-acting injectables available in mobile settings. So, in Chicagoland, I would love to see the Night Ministry, COIP, all of our harm reduction mobile services being able to offer people who are unhoused, people who have substance use disorder, access to these options in a way that does not require them to have to come to a physical clinical space, which they may have a whole host of reasons to not do, especially migrant populations. I guess both thinking about the patient and weighing the risk of them possibly being lost to follow-up and not being able to be found after that first injection, and the pros and cons of if we accept that as well, that is a possibility, but it's something that's still worthwhile to pursue, and how people feel about that at this point, how we can present that to a patient, that risk discussion without making it terribly scary. But then also how do we mitigate that risk from a facility standpoint so that our hospitals and stuff are willing to take this on without huge fear of litigation, which they are. So, our facility doesn't want to have condoms with our logo on it because a condom could break and we could be sued for, failure or something. So when you're dealing with that level of fear of litigation that we have in the US, I think, it would also be great for us as a community to be developing resources that help protect the facilities that are trying to serve these populations from this, what it feels to me a lot of times mythical big lawsuit that is coming after them constantly. But I know people do sue. We're a litigious society. So yeah, those are, I guess, my ask of if anybody is developing those kind of resources of, what kind of language or things can we have incorporated into consent forms or into something that helps make the facilities and all of their attorneys feel okay about the risks that are involved in doing long acting and offering it to populations who may have a higher risk of being lost to follow-up.
That's insane and awesome. I just kind of want to highlight something that I would love for us to explore as a public health community. And I was thinking about it the other day. So for cabotegravir, we don't want to lose the integrase class, right? Like that's like the big thing that everyone's like, oh my goodness, like we might lose that class of drugs. Like we want to be really careful. We want to make sure not like the barrier for resistance is low. Like let's make sure that patients are bridged appropriately. With the capsid inhibitors, and I'm not trying to be callous, I love a new class of drugs, but like if that's the only thing we lose, and we don't know about cross resistance, we don't know what that looks like. I would love to hear from like maybe Jenna, like if we lose the capsid inhibitors, we have all these other drugs we've been using for years. Too controversial? Should I leave? Cool.
We love controversy. Yes.
I think it's a little bit too early because we don't have that much information on capsid inhibitors, only for the past maybe 5 years or so. But I will say, because it is also used for multi-drug resistance, kind of as an additional class. I mean, there still is a risk there to lose that one, because it is also used in another population that has lost, a lot of the other drug classes. So I feel like it's a very risky and tricky conversation. So I don't know.
Sure. I guess I wasn't expecting. I was just like, we should think about it. Right?
Jenna's like, okay, yeah.
She's like, Carrie, slow you down.
I'm actively thinking it through too.
Okay. Cool. We'll think about it together.
So we are in our last moments together. We don't have to end right on the button, so I don't want to just shut this conversation down. I'm going to see if there's anyone else who wants to make a comment. I would love to
highlight Brooks's question.
Oh, please go ahead, please.
So Brooks, I know you're on an MMU right now, so you probably can't respond, but I love your question. Are there recommendations for substance use screening? I'm concerned about the interaction with ketamine, as many people who are using recreational drugs, they might not be aware of exactly what substances or they are consuming. Like I too am also very worried about this. I think before we start somebody on Len, I think we just need to really make sure to talk to folks about what they're doing when they're using recreational drugs. I completely agree with you. I think most people don't know what's in the drugs they're using, and we won't necessarily know. But maybe, I think we just need to include that better in our screening. But if other people have other ideas about, maybe someone could develop a ketamine strip for drugs.
I was just going to say that. That's a great idea.
Anyone want to get on that?
You all, I see the blueprint team. Let's do it.
We could maybe, I don't know, someone's
we can do everything.
Yeah.
Yeah, really great question. I think the interactions with ED drugs, so many of which are not done like through the conduit of a provider, ketamine that can be in all kinds of things, and then just this long tail that can last beyond 12 months. And so, will someone who was on Yeztugo and hasn't been on it for 6 months and goes out and does ketamine or pops a Viagra 6 months later, what will we don't know, right? And it's my understanding that there isn't a whole lot of desire to do more work on this from the pharmaceutical end, but I think we have to, as public health, folks and researchers, we gotta, if we want this to work for our communities, and a lot of the communities we're focusing on are using ketamine and ED drugs, and it's global too. It's not just like in the U.S. I do want everyone, I would love all the speakers. I'm going to give you a second to think. I give if you're in the elevator, you have 1 minute or 20 set, not even, let's say 15 seconds to say something to someone important about this. What is it? So what's your nugget, your takeaway? But I do want to bring up the last question in Sarit's list and just put it out there like as a charge for all of us. When we are so completely dominated by pharmaceutical money and interest and policy and direction in our community, and now really more than ever with the federal government backing away in all the spaces that we care about, from research to program to implementation to actually, to testing everything, right? And now pharma is increasingly taking this, is going to be in this very strong, stronger space than ever. We have to push back on these crazy amounts of profits. We have to. I mean, Yeztugo can be made for $25 a year, and $28,000 a year is the price tag in the United States. To everyone's point, like, yes, profit is fine. We should. This is where we live. We live in a profit system. But my goodness, this is going to make it very hard for us to implement. And the cost in other parts of the world is going to make it very hard to implement and have it make an impact other than on the bottom line of a pharmaceutical company. So I feel like we all have to be critical. We can be both friends with pharma and extremely critical of pharma when we need to be either. We really need to be carrying the water for public health in our communities first and foremost, and always center them. So I'm just putting that out there. Take that for what you will. I'm now going to go around the list. Maybe we'll go alphabetically. How about that? Starting backwards. So Sarit first. So give me your final nugget, and then we will close out the webinar. And we will go backwards alphabetically, starting with Sarit.
Well, look, you took all my nuggets. But what I would say is that, in my work lifetime, I started working in HIV in 1994. We have seen so many tremendous biomedical advances that have really changed our epidemic. And I think that that gives me tremendous hope that we can work together to continue our real commitment to the human beings that we are focused on serving.
Thank you, Sarit. And we will go, God, going backwards is hard. L would be next, and that would be Liz.
I think I would say that all of our blueprint resources are informed by the collective wisdom of providers and staff across the US. They are by and for you. And so hopefully it just frees you up to do more of what you're in it for, which is caring for people. So thank you all.
That is beautiful, Liz. Thank you. Katrine.
Yeah, I think I would just invite any of you who are still on or who are watching this later to reach out to us. We're always looking for ways to collaborate with the folks who are doing this work and serving clients and are in the communities. And we can as Liz said, we're learning from you, we're digesting what you tell us, and then we try to produce something that's useful to you. So we're always looking for more partners to do that together with. So get in touch.
Thank you, Katrine. Knock on that blueprint door early and often and ring their bell all the time. Jenna, you're next.
Okay. I just wanted to highlight clear and concise counseling would, like, to me, be the most helpful in both starting and changing meds for PrEP. We have across the board amazing results from all our PrEP options, and it's really dependent on kind of what the patient wants and what our internal teams can realistically make happen. We can't just promise everything to everybody. We have to be very realistic in kind of how we discuss things, but also try to follow through and make that happen with our resources. And I think even having modifiable resources and all that, like we've showed today, are a wonderful tool in ways that maybe some clinics don't have specific protocols in place. And let's see what other people are doing and try to kind of implement those. So stepping out a little bit and involving our patients and other healthcare professionals to get things done.
Thank you, Jenna. And Carolyn, you have the honor of doing cleanup.
No pressure.
No pressure.
So I would just like to, first of all, thank this forum. I think during a time when all of us are realigning where we get our information, I think having places like this where people can discuss things that are unbranded and also unbiased is really important, and we don't have very much of it anymore. So I think, thank you, Jim, for creating these forums. And I think in the future, this is going to be where we get this kind of information, which is wonderful because it's traditionally been such a foundation. But I think making sure that we're getting our information from places that are unbiased and unscathed. I think it's really important. So thank you, Jim, and thank you, everyone. This has been lovely.
Thank you, Carrie. I'm biased, but I have to agree. I think this is lovely too. This has been such a great webinar. And, you know, with everything we've been going through, this has been a hell of a year. Sucks in so many ways. But this kind of work that is stuff we can get our hands around and make a difference with. And I love thinking about Lens, not just as a lens, not just as its own thing, but as a lens, as a way to rebuild and reformat our work. Everything is being burnt down. We don't want to redo what we've been doing in the past because most of it was terrible and sucked, right? Infected with white supremacy, etc. So our chance now to rebuild systems that actually work for people and center community, and using some of these tools as a way to leverage that, a way to leverage Len to do that, I think is just, I mean, it's definitely put me in a good space today. So I hope it has for you as well. Huge thanks to the BLUPrInt team, to all of you, to everyone who registered, to the over 330 who will be looking at this at some point, hopefully. Please share this information with your colleagues and your networks around the country. We do want this information to get out. Help the BLUPrInt team, disseminate all these wonderful resources. And we will see you back at a TCA webinar in October. We'll be focusing on transgender issues, non-binary issues, and what's been happening with our government, both here and around the world. So stay tuned for that. With that said, I'm going to close out today. Everyone, thanks again, and we'll see you soon.